Right. Dr. Khalid, Dr. Lafont suggests that pacing should be continuing. Is that something that you consider, or why you stop at this stage because you want to avoid any pop-out or something at this stage?
Yes, we will pace when we release the valve. So we pace twice.
Right.
I think we release the valve here if you think the ice is good.
Any comment, Dr. Abdurrahman? You have a comment?
I mean, now he's almost done with the releasing of the valve, so maybe...
Okay, guys. So I think you're now at a critical moment now. So we're going to pull the picture off, rotate, and then release it, pull the wire slightly, and release slowly.
Yeah, we can see the wire. You moved it back a little bit.
Okay.
And,
stop pacing, release. Trace the 12 Slowly releasing the valve now. And I'm maintaining forward pressure. Okay.
Fantastic.
Okay, go into the coke line of your please.
Can we see the hemodynamics if possible a little?
Yes. Yeah, we will do that. We'll give you the hemodynamics. Give me. Let's have the sheet.
Also, it's very nice that they waited quite longer than usual because of the high implantation, just to make sure that this valve was not dislodged. And this is really...
I mean, we should give time in this case, for sure.
What's the height from the mechanical valve? You would start to be concerned, and why? We think the self-expandable is better than the expandable. So usually if the distance less than 6 millimeters, we start to worry about interacting with the mechanical valve. And if it's less than 6, we can say self-expandable, because you can position it more accurately. So the balloon expandable, the balloon extends beyond the valve, and you cannot be 100% sure how much shortening you get from the valve below. So you might get a cut or stuck with the mechanical valve and cause some bad complication. So in this case, we use self-expandable so we can deploy it more accurately, slowly, and make sure we are not interacting with the mechanical valve.
So you will have an echo now, Dr. Khalid? You'll do an echo transfer?
We will have an echo. We'll show you some hemodynamics here. Yeah. Okay. Forward. Back, please. Yes. Okay. Yes. Good. We're going to zero both our lines to get accurate hemodynamics. One of the things that after deploying the valve is accessible to biotic regurgitation. So we usually take an LVDT prior to valve implantation and we repeat it after. So if you can remember the first hemodynamics, there was peak-to-peak gradient of 50, and the LVDT was around 15. We need to flush the line again. We need to flush the line. Can I have one? And as I said, there are ways to evaluate your results. One is fatigue gradient, and the other thing is to evaluate the vertical regurgitation, which can be done by angiography or echo, or evaluate your hemodynamics. And usually if you have significant AR, you will see your LVEDT goes up, and that's the advantage of doing a pre-procedure hemodynamics. I think, what do you think, Abdullah? In the hemodynamics, ideally we don't have any systolic gradient. And we'd love to have significant systolic gradient, which we do.
Looks very
so
good.
We have the valve opening well, and there's not significant there, at least by hemodynamics. And you can see nice aortic notch there.
Great.
We're going to do an echo for you if you like. Dr. Nalini, please. While Dr. Nalini does an echo, we're happy to take any questions regarding the case, the steps that we have done.
Khalid, how is usually in the bicuspid valve your commissural alignment? What is the consideration different than the normal situation? How did you? What different you act like in a bicuspid situation for the commissural alignment?
I think this is a difficult question. I would love to hear from the panel how they do it.
Right, let's go, Dr. Abdurrahman. How do you deal with this?
It's well known that pathology of bicuspid valve is different than the normal aortic valve stenosis. So you would expect that the true annulus will be higher because you are taking the orifice of the aortic bicuspid valve as your annulus instead of the usual way of doing it. So usually it's higher, and the size is probably smaller. And then you have to, that's why we need to do pre-dilatation with the balloon that will seal completely the valve when you are preparing the lesion before putting the valve.
Dr. Mohammed?
I think the alignment, most of the time, it's the same. You go with the port and you follow all the instruction for the same alignment. But I think the consideration, this is not a normal pathology. It's a bicuspid. And I think the steps they did here, the preparation, the pre-dilatation, and even without a valve in place like mitral, most of the time in the bicuspid, you want it to be higher up than usual, little bit. Sizing, a lot of the operator, they little bit downsize in cases of bicuspid aortic valve. Still, the question of this lady, she's relatively young, and if it is a heavily calcified bicuspid aortic valve, and there is a valve before, I think, just keeping in mind the sentinel or protection device, I think it's advisable in such cases.
Yes. Well, it's still, there's no such consensus, still it is operator.
Even the trials, but
right.
It depends. Some of the centers, they are doing it in most of their cases, but the problem with the stroke, sometimes you might see the stroke later on, not on the same day.
But we don't have still yet so much clinical data, strong clinical data to prove the really benefit from this. So I think we need more data to prove that one. Albert?
I think there's ongoing 2 trials now looking at the cerebral protection. Indeed, we're all looking forward to see those results of those. And as always they say, at this stage, I think the consensus is it's better to be in the basket than to be in the brain. I think we all agree on this one. And Sentinel is a simple device. It can be deployed within a few minutes' time, safe, no side effects. But in this particular case, I'd agree with that. Probably using the Sentinel is wiseable.
We have in our center, for instance, we are doing it almost 90% of the cases now, and we always find debris. But what I want to say is still we are far ahead from showing the long-term clinical outcome benefit from this device. But we think that it's kind of, there is certainly some rationale behind it and some evidence already available, certainly.
And I think
Dr. Lafont, do you want to comment on this Sentinel device in this situation and where we are so far, and how's your practice in your center?
Many studies have shown that their NMR post-TAVI is really frightening, but there is a clear discrepancy between the images and the clinical outcome. So The question is whether we should define high-risk people in which Sentinel or any protection device should be mandatory. But enlarging systematically, I think there is no yet the data to show it.
Right. Thank you.
It is exactly for the coronary, where finally the protection system didn't show any significance in terms of randomized.
Thank you, Dr. Lafon. Actually, I just got a question that there is a mild earthquake. Maybe that is the problem in Kuwait. Salamat shabab. Inshallah, Allah يسلم الكويت. وإن شاء الله ما فيكم إلا العافية. Khalid, the floor is yours, Khalid. Anything you wanted to add? Sorry, because Dr. Lafon was talking. Please.
Yeah, we're going to. We had an echocardiography, and there is trivial posterior aortic regurgitation, and you can see the angiography now here with injection. Peak-to-peak gradient is almost less than 10 in the cath lab, and then by hemodynamics, and mean gradient is around 5. It's around 5 millimeters.
And
so I think this is a nice, acceptable result.
Yeah, I think it's
another advantage we have from landing high that there's no heart block or convection delay.
So, what do you think, the panels? Maybe we take opinion. Would you go for post-dilatation? Would you stop here? This is a reasonable, looks to be a good result.
I think this is a good result. I will stop here and I will not distort the anatomy.
Muhammad?
I think the gradient is beautiful. Like he said, it's low gradient, and we know from the self-expandable, just give it little time, and even the mild, maybe trace, they disappear. And this is the most advanced type of Medtronic with a nice seal and nice delivery system. Yeah, I think I will leave it at this stage, and we are happy.
Albert?
Yeah, I agree entirely. I don't think it's indicated in this case. However, in bicuspid valve with high calcium score, I think there are some cases where you need to post-dilate and prevent, particularly if we're going to start implanting in a young patient, not specifically this one.
Hello?
Aywa Khalid.
We can't hear you now.
Khalid, I mean, we have kind of consensus here that we shouldn't do anything more here.
We can't hear us. We can't hear you. We're going to remove the sheet.
Okay.
Can you guys show the group?
The patient had from the beginning moderate AR. We shouldn't forget this. He had calcified there, and we have already the new product of the Evolute Pro with the precardial skirt outside or wrap. So that will take care of a self-expandable. We know that by time it will seal that as well. So.
Can I just make this comment, Dr. Arif? It's whoever was in Paris for the EuroPCR, probably in the innovation session, they've seen the Gemini device, which basically it's like rotablation for the coronaries, but it's debulking the aortic valve. And it's very smart, intelligent invention. Really, I think it's the future. Perhaps we use the Gemini to start with and then deploy the TAVI whichever way. Because once we start deploying TAVI, which we will be in young patients, I think the longevity of the valve will rely on the paravalvular leak or on how perfection we should aim during the procedure. For this particular patient, I think that doesn't apply. However, for a future reference, I think devices to debulk the valve prior to deploying the TAVI device becomes more significant.
Well, I'm sure that we are coming across so many new technologies. I have seen that new technology recently, and it's really by debulking this. I don't know, but we need some more data, certainly. There are a lot of technologies coming ahead, especially that we are going deeper and deeper in the more complex situation, younger ages. Now we have the indication wide into less risk population. So it is going to be challenging, but we need to optimize certainly our techniques and our devices. So, yeah.
Can I make one comment about the commissure alignments? In every valve, there are criteria now and guidelines how to do the commissure alignments. I mean, we all agree that it's done in the bicuspid valve. So for the core valve itself, I think it's very clear how to do it. But the other valves, I think we need to be trained. There is a learning curve about this. And again, for the same reason that in the future we'll be using it in young patients, we need to make sure that we have coronary access. And the commercial alignments is the key to make sure that we do have coronary access when somebody presents with acute MI.
Right. So Khalid, back to you. This patient is anticoagulated. He has a mechanical valve in position, the St. Jude and mitral valve. And did you have any special approach regarding the anticoagulation, antiplatelet? What is your plan there?
Just one quick comment on AR. Basically, we have to be realistic with the patient's result. So our aim is basically we don't get no AR or trivial AR and do our best to achieve that result. But sometimes you get an elderly lady or man who's having limited mobility and functional status, and he has lots of calcification, and you end up by mild plus maybe moderate AR. Sometimes in some situations you may have to accept more than mild if the risk is higher in patients. I don't know if they can see the ultrasound, but we are imaging. I want to show you, we did ProGlide, and you can see clearly there is a nice femoral artery after the ProGlide, and we don't need to do a peripheral angiography. And Abdullah will do the longitudinal view to show you the flow.
Khalid, when you did the puncture, was it ultrasound guided or angiographically guided? Or how do you do that usually in your practice?
I would ask Abdullah to tell you how we do this usually in our center. To be honest, in our center, all the punctures done for TAVI is done with ultrasound guided, including femoral, arterial, and the venous. And then by and large, all the femoral arterial access for non-TAVI is also done with ultrasound. To be honest, our experience with ultrasound has been really good. Since we adopted this technology, the risk of complications went down a lot.
I think that is the trend now. And, we believe that will add a lot of benefit for the patient and reducing the peripheral complications. Are we all doing this ultrasound guiding from the panel, Mohammed? How do you do it?
I think, as you remember, we started with the typical fluoro guided. Now we introduced the ultrasound guided, and you can see the bifurcation nicely, and you can see the calcium. And I can say it's up to maybe now ultrasound. It's invading the cath lab more than usual. Some of the newly interventional guys, their training from outside was in ultrasound. They were not so expert on the fluoro. But we are doing both, and we are doing more intravascular, ultrasound-guided puncture. Even some of our colleagues for the femoral approach for coronaries, which is good, micropuncture. But yesterday we saw a lot of data. Like when you go to data, there is no huge difference between the two outcomes. But I think the trend now it's for more ultrasound.
I think it is also related or correlated to the learning curve and your experience of the operator, Abdurrahman.
Yes, I think the ultrasound guided is a new and nice procedure. The problem is really operator dependent. So whoever do it, you should have good training on this and to accumulate with time. I have some cases where I fail to do it ultrasound, so I do it angiographically. I still trust my old, style.
Actually, from my point of view, it has a big difference in your outcome, especially for vascular, because sometimes you will not recognize a calcification and you puncture in a calcific spot. Just if you go 1 centimeter above, and it will make a huge difference.
Yes.
And the tip here is, as Dr. Muhammad said, that you should use it in not only on for TAVI cases or femoral approach cases, and even for radio sometimes we're using it. So you get more used to using ultrasound guided.
To be honest, I think we found that ultrasound sometimes is time consuming. And I think regarding the calcium issue, you should know this from your CT. So you should plan this ahead of time.
So I think we'll come across debate here now about ultrasound favor and or not, who is in favor of which CT.
Can we add one small
Khalid.
comment here?
Sure.
Basically, when you start doing ultrasound, you should mark your head of the femur with fluoroscopy, and we can show it here how we do it, because you tend to stick higher with ultrasound. So look at that. So what we do, usually we localize where's the head of the femur, and then we go with the ultrasound and we stick wherever we think it is the common femoral. And once the wire is inside, we fluoro again to make sure the needle is and the wire in the right spot. Because with ultrasound, it's a great tool, it's excellent, but you tend to stick higher. So if the stick is higher than what we think it is the right, we just take the needle out. This is the way how we do it.
This is a fantastic demonstration of the combined method. I mean, you use every tool you have available, and every tool gives you additional information. So why not using all the tools and all the information is available? That's ideal. Perfect. So maybe we ask one more question, Khalid, since we have time. You have used a temporary pacemaker. You are not using the normal other way of using a percutaneous or one without a separate temporary wire, using just the LV wire, guide wire as a pace for pacing?
So maybe I respond to this question. We did use this technique before, we have used it a few times, but to be honest, we feel more comfortable with transvenous pacing. It's more reliable. And in many of these cases, you want to keep it for 24 hours in case patient develops new conduction delays with the self-expandable valve. Some people like it. We've tried it before, but we feel more comfortable with the transvenous pacing.
Any comment from the panel, Muhammad?
I think I will agree, especially with the self-expandable. Sometimes you see some conduction delay, or, it is reasonable to keep it, but not in every case. Even with the self-expandable, sometimes, or a good time now, with high implantation, we're having a good result, and you remove the pacemaker and the cath lab.
Any comment?
I think I think this case is an example of this. I think we removed the temporary pacer.
Certainly, that was a good case. Any comment about single-axis TAVI that recently been introduced?
We discussed this before about single-axis. Simon Redwood, they're publishing data now about single-axis. I know you access the radial for your pigtail, which is fantastic. That doesn't count in multiple-axis, but we've seen many cases where both femorals are used. I think in those cases, certainly there is a benefit from Simon Redwood. You said about 23% less vascular access. So single-axis, I think with the experience learning curve, once you reach that level, I think it's probably the future. We try to simplify the procedure as much as we can.
Good.
Can we respond to this, please?
I think the earthquake has hit our technical team here rather than Kuwait now, unfortunately.
Just go back to the ultrasound. I'm using ultrasound even for the venous. Sometimes when you do mitral clip, mitral balloon valvoplasty in obese ladies, I think it's very good idea to use ultrasound. Yeah, it's very helpful. I agree.
Khalid, are you gonna continue with aspirin or DAPT or anything additionally, or you'll just continue with the anticoagulation? Because I knew that you are continuing with the anticoagulation. You did not change his patient's anticoagulation in this situation, isn't it?
Yeah, we're going to keep the anticoagulation alone, no aspirin. It depends which data you're following, to be frank with you. But this lady has been having some bleedings and getting recurrent transfusions. So I think dropping the antiplatelet is wise. But we need to respond to the single axis. I don't know, what do you think, Abdul, about this? I think it's good to know that you can perform TAVI using a single axis, because in some cases that might be helpful. Having said that, since we've been using ultrasound guidance, as well as using radial access for the secondary arterial access, we haven't seen any problems. I mean, many times we need the other arterial access to check pressures, to do a root angiogram. I think it's very helpful. It's still self-expandable. Yeah. So you wouldn't use a single access for a self-expandable. And the risk of complication with radial access is minimal. So the risk 30%, 25% is applied to the femoral axis, to be frank with you, not the radial axis. But definitely it could be used in special certain situations, and it has to be a balloon expandable valve.
Right. This patient is on heparin now. She's interrupted her warfarin or not?
Yes, which is
on heparin for the procedure, right?
I think he was already anticoagulated. Did you add any more heparin? Khalid, the question from Dr. Abdurrahman.
Was the warfarin or anticoagulation interrupted to start heparin for this procedure or not?
Did you interrupt the anticoagulation? No, according to my knowledge. Did you add any heparin extra for ACT control?
So this patient was switched to low molecular weight heparin.
Yeah, okay, so
and was not given the dose of low molecular weight in the morning of the procedure, and we gave her heparin intraoperatively. So she will be back now with low molecular weight heparin, and she will bridge to warfarin once the INR therapeutic.
Okay, thanks.
Thank you. And one thing, Khalid, I was discussing this matter with the surgeon in our house. So I was thinking, is there any concern from the mechanical valve by placing my wire, the guide wire? I mean, I don't know which wire you have used. Safari was it or Confida? I don't know which wire you used, first of all, the size, the small one, the extra small, the large. Which one did you choose, first of all?
We chose the Safari small, and whether this is a mechanical valve or non-mechanical valve. When you cross the valve, you have to make sure that your wire is not interacting with the mitral apparatus. So once you cross, you go to the area of projection and go with a pigtail and make sure that it's free, it's not interacting with the valve. And this applies to the same mechanical valve. You don't want to be, you have to be sure about your position. Yes, the wire can go between the discs. Yeah, things can happen that way if you're not careful.
Yeah, actually what our surgeon was mentioning, since it has been, the surgery was done 2008, according to the history that you have presented, and they said they have the single leaflet or double leaflet, so that plays also some kind of reducing the concern. I mean, if it's single leaflet, it is deeper, the profile is larger, and if it's a thin or double leaflet, it is less profile and less concern about the complications. So it's good always to have, listen to the surgeons, what they say, the comment before. I was really interested and excited to hear from them. So that's one of the points that our team can add, really sometimes additional information that we miss as interventionalists, just to share with you with comment. Nothing there. Thank you.
Sure.
Any further questions from the audience? Hussam, comment, Fuad, anybody? Okay, I think...
we have one comment before you go. if you have a single leaflet mechanical valve, it's usually bigger, as you said, and it's more challenging. The risk with that is higher. Bi-leaflet valves, they have, less risk compared to the single leaflet. Yes, that's true. And we're lucky this lady has St. Jude valve.
Right. I think Khalid Abdullah, you have demonstrated great case, fantastic, really very provocative case. It made us all alert and paid full attention. And I really feel bad about the situation in Kuwait now with the earthquake. So you did really work hard. You have given your time, everything to your patient during such a situation. Inshallah, everything will be fine. And congratulations. Really, everyone is, I think, happy about the case, the result. Big applause for you from the audience. And
thank you very much, guys.
It was our pleasure. Thank you very much, and have a good day. Bye-bye.
Thank you very much.